Do you ever have trouble figuring out which vasopressor you should use when you're resuscitating your hypotensive patient? Well, today I'm going to go over the menu of options that you have when you're resuscitating your patients. Let's go. Now, the good news is you have lots of vasopressors to choose from. The bad news is that most of them are not very good. The first one we'll talk about is dopamine. This is a classic. It is vintage. The problem is it's not very good. Dopamine used to be one of those frontline vasopressors that we used, but it turns out there's an increased rate of atrial and ventricular tachydysrhythmias, so it's not that good for routine use. In fact, you really have to look and find an indication for it, and it turns out that the only real indication we have for it is hypotension plus bradycardia. Other than that, it's not really a vasopressor that you want to be using. The next one we'll talk about is phenylephrine. This is pure alpha in a bottle. And this is also a good vasopressor because it causes direct vasoconstriction. But the problem with direct vasoconstriction is if you have a heart that is not working so well and you increase the afterload, you make this heart work more. And a heart that works more is not happy. It increases the workload and ultimately can decrease the cardiac output. So for that reason, phenylephrine is also not a first-line vasopressor. So you might be asking, when would you use phenylephrine? Well, a good indication to use phenylephrine is for brief periods of hypotension, like during RSI. During RSI, you might use vasodilatory meds and you use phenylephrine just to temporarily overcome that vasodilation. Another really good indication to use this is when you have a person who has atrial fibrillation and you want to cardiovert them and they're awake, you want to give them some sedation, which may cause hypotension. Give them a little bolus of phenylephrine and this will increase the blood pressure, allowing you to give sedation and analgesia and then do your cardioversion in a more humane way. Let's move on and talk about some drugs that we might actually use in our clinical practice. And for that, we have to talk about norepinephrine. Now, norepinephrine used to be leave 'em dead, and that's a joke that I learned during training. But the truth is norepinephrine is the go-to vasopressor. It's really the best of all because it has alpha, so you get afterload increase, but you also get beta. And what that means is that this increases contractility of that heart. Remember what we said about phenylephrine before? We increase the afterload and that puts pressure on the heart. Well, if you increase your beta, increase that squeeze while you're increasing afterload, this becomes more of a balanced vasopressor. Another neat feature of norepinephrine is that it increases venoconstriction. And the benefit of this is that this is going to increase the blood flow coming back to the heart. So again, this is really the king or the queen of vasopressors. This is the one that we should be using for almost all causes of shock. Nothing is perfect, and certainly this is a drug that is not perfect as well. Things you want to keep in mind is that this could increase arrhythmias because that beta can tickle that heart. So just be aware, if someone is sensitive to this, you may look for a different vasopressor. But this is the workhorse that we use for septic shock. This is our first line agent for cardiogenic shock. This is really the drug that you would want to use for almost all cases. Can't talk about norepinephrine without talking about epinephrine. Epinephrine has alpha and it has beta. The problem is it just has a little bit too much beta here. This increased beta can cause a little bit more arrhythmias than norepinephrine, and that's the reason why we go with norepinephrine before epinephrine. But epinephrine's a really good drug and has a lot of the similar features that norepinephrine has. One other thing to keep in mind when you're talking about epinephrine is that it increases lactate production. So if you're following lactate to monitor your patients, you might notice an increase in lactate that is not due to the patient's clinical condition getting worse. It's actually due to production from epinephrine use. A quick little feature about epinephrine that we'll talk about briefly here, but we won't go into great detail, is the fact that epinephrine at low doses works more as an inotrope, and as you increase your doses, becomes more of a vasopressor. And this is due to the fact that at low doses, there's more beta activity, and at higher doses, there's more alpha activity. When we say low dose, we're talking about 0.01 to 0.05 mics per kilogram per minute. But inotropes in general is a talk for a different day. Now, when you need to add on a second vasopressor to norepinephrine, what are you going to use? Because again, norepinephrine should be our go-to first-line agent. Well, the agent that most people like to use is something like Vasopressin. Norepinephrine works on alpha and works on beta. Vasopressin works on the V1 receptors, and this increases afterload. But it does so on a different receptor, so these work synergistically. Rather than starting norepinephrine and epinephrine, which would be working on the same thing, adding vasopressin gives you synergy between these three different sets of receptors. Vasopressin is good because it doesn't only increase afterload, but it also increases cortisol production. It also increases insulin production. It also works on the kidney to increase GFR. Now, I don't mean to nerd out on you, but these are all important things when you have somebody who is critically ill. So vasopressin is a really good drug for the vasopressor effect, but it's also a really good drug for everything else that's happening. So use it in conjunction with norepinephrine. Another feature about vasopressin that's really nice is that of all the vasopressors, it does not increase pulmonary vascular resistance as much as the other ones. And you might be saying, well, who really cares about pulmonary vascular resistance? Well, you should care if your RV is sick. A sick RV does not like resistance against it. So vasopressin is a really good vasopressor for people like this. And in fact, when I have somebody who has pulmonary hypertension and is sick, I might actually go for vasopressin first. But just keep in mind, vasopressin works synergistically with norepinephrine and does not increase pulmonary vascular resistance as much as the other one. Now, the final vasopressor I want to talk about is one that I actually don't use because it's very, very expensive and I don't have it in my hospital yet, but we can talk about it. It's called Angiotensin 2. Angiotensin 2 has been studied in patients with septic shock and distributive shock, and like vasopressin, works in multiple sites in the body. It works on the vasculature, it works on the kidney, and so there's lots of benefits to considering angiotensin 2. But as I said before, the problem is that it's very, very expensive, and not a lot of hospitals have this right now. So as this becomes more available, we'll have a lot more experience and a lot more studies to tell us whether or not this is going to be a good drug for the future. But for now, for most people, your main workhorses are going to be norepinephrine and vasopressin. Now, just take one step backwards here for a second, because I forgot to talk about when do you add vasopressin when you have somebody in norepinephrine. This is a very, very good question with no good answer. What I'll say is that when you have a patient who has norepinephrine and you're typically in your mid-teens dose, like 13, 14, 15 of norepinephrine, then I'll go ahead and add vasopressin on. So just as a review, dopamine, nah. Phenylephrine, meh. Maybe you're going to use it for the person with AFib and hypotension, giving them some afterload increase to give them sedation and analgesia. Norepinephrine, this is the workhorse. This is the best vasopressor for most types of shock. Second line agent, vasopressin, and then angiotensin 2. We'll just have to wait and see. But remember, you need lots of moolah if you're going to be using angiotensin 2. Thanks for watching. My name is Haney, and you can follow me on Critical Care Now. Probably can't even read my handwriting.